Artificial intelligence appears to be making a difference to brain surgery while the patient is actually on the table. A US study has found that computer-based diagnosis of brain tumours using sophisticated algorithms can be as accurate as the best neuropathologists, potentially saving time in theatre and giving neurosurgeons more confidence in the extent to which they've removed the tumour. Daniel Oringer is Associate Professor of Neurosurgery at New York University Langone Health, and I spoke to him earlier.
My pleasure. Thank you so much for having me.
What tumour are we talking about here? Is it glioblastoma, the most malignant form of brain tumour?
Well, that's exactly right. And the technology that we've developed actually applies to the 10 most common brain tumors. Glioblastoma, of course, is the most feared of those. But we've developed technology that helps surgeons make a diagnosis across different types of brain tumors in the operating room at the bedside within minutes.
Take us into theatre. Describe what's going on and the dilemma faced by the surgeon at a certain point in the surgery.
The primary goal of any brain tumor operation is to establish the type of tumor that we're dealing with. That's essential for making decisions. And as surgeons, we can see when we've encountered abnormal tissue, but an analysis of that tissue under the microscope is required to differentiate among the different types. Conventionally, the way that we do that is by taking tissue out of the patient and sending it to what's called a frozen section lab that's disconnected from the operating room. And in that lab, the tissue is processed and a technician creates slides for a pathologist to review, and the pathologist calls back into the operating room with a diagnosis.
In the meantime, you're standing there twiddling your thumbs and the patient's under an anesthetic.
Exactly. And that process can take 30 to 45 minutes. And what we've designed is a system that eliminates a lot of the cumbersome portions of that workflow. And instead of using a separate lab, we're using a breakthrough in optics called simulated Raman histology to allow us to use fresh tissue at the bedside to create a virtual histologic image or microscopic image of the tissue in just several minutes.
Just describe what happens, because normally, as you say, you take a lump of tissue out of the tumour, it gets frozen, and then they slice the frozen section into microscopic slices, look it under the microscope, and see whether, what the features are, whether it's glioblastoma or a meningioma or something like that. So you take your lump of tissue under this simulated histology. What happens to that lump of tissue?
So you described the conventional process very well. Our workflow is very straightforward. Tissue comes out of the patient using a surgical instrument. It's placed onto a carrier slide, and that goes directly into a slot in an imager, and then we close the door and the imaging happens automatically.
So through a thick section, so it's a lump of tissue, not a thin slice.
That's right. The architecture of the tissue is not destroyed, and based on the light that's passing through the tissue, we can generate a virtual histologic image. After we have the image, it needs to be interpreted. And what we've developed, because there is a gap in the knowledge of surgeons in general, is an artificial intelligence method based on image classification that can predict tumor diagnosis based entirely on the digital images that we generate in the operating room. And given the power of this algorithm, we're able to achieve expert-level diagnostic classification that rivals the accuracy of some of the best neuropathologists on the planet. But as you alluded to, there are errors that are made. And we found in our study of 278 patients, there were a number of errors that the algorithm made, and there were a number of errors that the pathologist made. What was really interesting is that the errors that were made by the pathologist and the errors that were made by the algorithm were entirely non-overlapping, meaning that we can imagine a way of the pathologist using this algorithm to achieve almost perfect accuracy.
But how does it work the other way when you're just a surgeon in the operating room? You've got the virtual histology done, the AI is telling you it's okay, it's not a glioblastoma. You haven't got the luxury of a neuropathologist to then look over your shoulder and say, sorry, chum, it is.
In the United States, hundreds of hospitals that perform brain tumor surgery don't have a neuropathologist on staff. And what our study suggests is that in those settings, they can use the algorithm to help close that gap.
And if you're operating in a major centre where there is a neuropathologist, what's the practice? Because in Australia, my guess is that most potential glioblastomas are operated on in major centres where you would have neuropathology on call.
Yes, even our colleagues here, who I would consider world-class, operate at an error rate of approximately 5 to 10%, which is quite admirable, except if you're one of those patients that's in the 5 to 10%. The hope is that with the algorithm, we might be able to boost the accuracy of intraoperative diagnosis closer to 100%.
Once the tumour's been removed, particularly in something difficult like glioblastoma, the difficulty is knowing whether you've got the margins clear. Does this help?
Yeah, so this is why I got into this business in the first place. As a medical student, I appreciated the challenge that neurosurgeons have in the complete removal of a brain tumor. Differentiating healthy brain from brain that's been infiltrated by a tumor is very, very challenging. Neurosurgeons have to guess at the margins. But to me, that wasn't good enough. And my practice now is very different because I have this system that allows me to objectively determine the degree of tumor cell infiltration in the tissue that I'm operating on. For example, if we're in an area of the brain that is not essential for motor or language function, my goal is to, and I'm obsessive about this, is to remove as much of the tumor as I possibly can, even down to the point where I'm removing individual tumor cells that I detect on the microscope that I wouldn't otherwise be able to do. So having the system at the bedside allows a level of accuracy in brain tumor surgery that was not previously possible.
Thank you very